Our lecture for today is going to be on the Parkinson's disease and the drugs that are used for Parkinson's. So, if we're talking about Parkinson's, it is important to know that it is a disease that is caused by the loss of dopaminergic neurons and there is excessive cholinergic activity. So, in short, if we look here, we have Parkinson's. In the Parkinson's disorder, there is decreased dopamine and there is increased acetylcholine. So we obviously need drugs that will increase the dopamine, that is dopamine agonist, and we also need some drugs that will block the acetylcholine, that is acetylcholine receptor blockers. So apart from this, we should know that there are dopaminergic neuronal pathway works through 4 tracts. So in the CNS, dopamine is basically a precursor to norepinephrine, and it works as an inhibitory neurotransmitter in 4 major dopaminergic pathway. The first pathway is the nigrostriatal pathway. The nigrostriatal pathway is basically responsible for, in the nigrostriatal pathway, dopamine is responsible for the movement, and the nigrostriatal pathway is the main pathway that we are concerned about because it is the pathway responsible for Parkinson's disease. What happens is that there is loss of dopaminergic neuron in the substantia nigra, which causes low level of dopamine, and the reason for this can be that it can be caused by drugs that block the dopamine, that is the dopamine receptor blockers, which are used for schizophrenia. It is important to know that while treating Parkinson's, you can cause schizophrenia, and vice versa, while treating schizophrenia, you can cause Parkinson's, because they both are opposite of each other. In schizophrenia, there is excessive dopamine, we need to block it, and in Parkinson's, there is low dopamine, we need to increase the amount of dopamine. The pathway that mesolimbic mesocortical tract, this is a pathway that is concerned with schizophrenia that we will talk about later while we're covering psychiatry. So we're not concerned with this. The only thing that we need to know is that in this pathway, dopamine is responsible for behavior, which is obviously why you should be concerned about in schizophrenia. And in this pathway, any drug that will increase the dopamine can obviously increase the chances of psychosis. So if you're treating someone for Parkinson's, you're giving them dopamine agonist drugs, you will end up in resulting in, it can end up, it's a side effect, so it can end up resulting in psychosis. The third pathway is tuberoinfundibular, and in tuberoinfundibular, dopamine naturally inhibits prolactin. So for hyperprolactinemia, you can give dopamine agonist to decrease the amount of prolactin, and vice versa, dopamine antagonist, they will increase the prolactin amount. Dopamine is basically naturally responsible. It is naturally responsible for inhibiting prolactin in our bodies. And obviously, a dopamine blocker will increase the prolactin and can cause amenorrhea, gynecomastia, and endocrine dysfunction. And the last one is the chemoreceptor trigger zone. And the only thing that we need to know is that dopamine receptors increase emesis. So if we give a dopamine drug, you're more likely to experience nausea, vomiting, whereas a dopamine receptor blocker works as an antiemetic, so you can decrease the symptom of nausea and vomiting. Now, if we come towards this again, Parkinson's disease is due to the loss of dopaminergic neuron and excessive cholinergic activity. It works through the nigrostriatal pathway. The main drugs that we need to know in Parkinson's are bromocriptine, amantadine, levodopa, salicyline, and antimuscarinics. So the mnemonic for this is BALSA: bromocriptine, amantadine, levodopa, salicyline, and antimuscarinic drugs. The first thing that we need to know is about this diagram is that the drugs work through this pathway. So the pathway that this is basically, it's showing you how the dopamine affects different receptors. So right here is a dopamine receptor, and a dopamine agonist drug will obviously activate the dopamine receptor, and the dopamine agonists include ergot and non-ergot drugs. Ergot is bromocriptine, which is not used now because of a lot of side effects. And then we have the pramipexole and ropinirole, which are non-ergot drugs. They're popularly used for restless leg syndrome. The side effects of pramipexole and ropinirole include nausea, impulse control disorder, that is gambling, postural hypotension, hallucinations, confusion. These are the side effects that a dopamine agonist can cause. The next, we need to know about increased dopamine availability. So increased dopamine availability, what we mean by that is we need a drug that will block the muscarinic receptors. So the drug that blocks the muscarinic receptor is amantadine. By blocking the muscarinic receptor, it will block the action of acetylcholine. So it increases the dopamine release. So this is the mechanism of action of amantadine. It will increase the dopamine release and it will decrease the dopamine reuptake. And the toxicity or side effects is that it can cause peripheral edema and livedo reticularis, which is the most important side effect. What is livedo reticularis? It is basically a purplish skin discoloration, and there is also chances of ataxia. The third category of drug that we need now is the drugs that will increase the levodopa availability. So the levodopa availability is increased by levodopa and carbidopa. Why do we use these two drugs in together? Is because carbidopa blocks the peripheral conversion of levodopa into dopamine by inhibiting dopa decarboxylase. Dopa decarboxylase is the enzyme that will convert levodopa into dopamine peripherally, but we do not need levodopa peripherally, we need it centrally. So it basically acts as an inhibitor of dopa decarboxylase and reduces the peripheral side effects of levodopa conversion into dopamine, causing nausea and vomiting. Another important category that we need to know about is entacapone and tolcapone. Entacapone and tolcapone, as we can see here, are COMT inhibitors. COMT inhibitors are basically inhibiting COMT, which converts dopamine into dopac, and also centrally it converts dopamine into 3-MT. So it basically inhibits the COMT in here and prevents its conversion into dopac, because we need dopamine, not these end up products. So the COMT inhibitors include tolcapone and entacapone, and they are basically preventing the levodopa degradation into oh, I'm sorry, I messed up here. So the COMT inhibitor converts it into 3-O-methyl dopa, and we prevent it, not the dopac. Dopac is what the monoamine oxidase B inhibitor does. We will get into it later, but anyways, the COMT is basically preventing the levodopa degradation into 3-O-methyl dopa, and it is used in conjunction with levodopa. So the next drug is the drugs that prevent the dopamine breakdown. The drugs that prevent the dopamine breakdown are the drugs that act centrally, that is in the after the blood-brain barrier, after it has crossed it, to inhibit the breakdown of dopamine. There are two drugs. COMT inhibitor works peripherally as well as centrally, and the central action for COMT inhibitor is by tolcapone. Tolcapone basically inhibits dopamine to convert into 3-MT, that is in the brain, and we need dopamine, not 3-MT, so it inhibits it. So tolcapone is used as a COMT inhibitor, and the second drug is the monoamine oxidase type B inhibitor, that is seleglene and resiglene, and these drugs basically inhibit the monoamine oxidase type B and prevent the conversion of dopamine into dopac. So these are the two drugs that prevent the dopamine breakdown and are very important. And then we have some curb excess cholinergic activity, which is caused by benztropine trihexyphenidyl, which these two drugs are antimuscarinics. We also need antimuscarinics to improve, which improves the tremor and rigidity, but it has little or no effect on the bradykinesia that is caused in Parkinson's disease. If we look at the mechanism of action of carbidopa and levodopa are basically increasing the dopamine in the brain. However, Levodopa crosses the blood-brain barrier and it is converted by dopa decarboxylase in the CNS to dopamine, and carbidopa prevents its conversion into dopamine by acting peripherally, and it inhibits carbidopa basically inhibits dopa decarboxylase peripherally, so that more levodopa is available centrally, not that we need it peripherally, because we obviously need levodopa to work centrally in the nigrostriatal pathway. The use of carbidopa and levodopa is in Parkinson's disease, and the side effects is that it can cause nausea, hallucination, postural hypertension, and also a very important side effect is on and off phenomena. So what does it mean by that is that the on and off phenomena is that during the on periods there is improved mobility, and then the patient basically experiences impaired motor function during the off period. So this is how the side effect works, and then it occurs when patient responds poorly to levodopa. Salicyline and racicline, as we all know, is a monoamine oxidase type B inhibitor. It blocks the conversion of dopamine into DOPAC by inhibiting monoamine oxidase type B, which is more commonly found in the brain than the periphery. And its use is that it is an adjunctive agent to levodopa in the treatment of Parkinson's, and it may enhance the adverse effects of levodopa. So that's all that you need to know about Parkinson's disease treatment in step 1 exam.